Hi, I am Dr SVSS Prasad, Medical Oncologist in Apollo Hospitals, Jubilee Hills, Hyderabad. My special interest is pediatric oncology, and I would be talking about neuroblastoma today. Neuroblastoma is a childhood tumor. Diagnosed and treated properly, we can have good responses including cures, and it can occur either in infants or it can occur in children more than 18 months to 2 years of age. When the patient presents with a mass in the abdomen, usually a mass in the abdomen, that is when the diagnosis process starts. We will be doing CT scan or an MRI, and then we find a adrenal tumor mass. This needs to be biopsied. Generally we call it as a core needle biopsy, and then in the histopathological examination a neuroblastoma diagnosis is made. Of course, there are immunohistochemical markers made to confirm the diagnosis, and we also have some blood tests which will support this diagnosis called HVA and VMA, vanillyl mandelic acid and homovanillylic acid. So these help us. If they are increased in the blood, they also support the diagnosis of neuroblastoma. Once diagnosis of neuroblastoma is done, then we have a staging investigation. We need to stage again with a CT scan of the abdomen or an MRI of the abdomen. Of course, in some centers we have the PET CT scan of the abdomen, which will show us as to what is the stage, as to where all it has spread. And neuroblastoma can just be localized to the adrenal gland area where it has arisen from, or it can go to areas like liver or the bones or sometimes bone marrow. If we want to know whether it has gone into the bone marrow, we need to do a bone marrow biopsy, which often we do in these cases. Sometimes in the clinical picture, in the blood test itself, it may be revealed in the form of lessening of the white blood cells, lessening of the platelets, fall in the hemoglobin, and so on. So we stage the neuroblastoma. If we have a suspicion that it has spread into the bones, then we can do what is called as I-123 MIBG scan. And so this MIBG scan will tell us whether it has gone into the bones in a more clear manner. This might also be revealed in what I said earlier as the PET CT scan. Once we do this, we also do certain genetic tests or molecular profile on the biopsy specimen, and things like NMYC antigen, and we have loss of homozygosity in the 1P gene, and so on. So these molecular biology studies will tell us whether the tumor is of a higher risk or a lower risk. So once all these things, the diagnosis and the staging investigation and the molecular profiling is done, we now classify the neuroblastoma either as a low risk or as an intermediate risk or a high risk tumor. Well, of course, we have stagings and risk profiling systems called International Neuroblastoma Staging System, and nowadays what is called as some of these molecular profiles being added to the risk profiling system. And so International Neuroblastoma Risk Profiling System is also there. Once this risk profiling is done and we categorize into low grade or low risk, then we can straight away look at surgery as an option. If it is removable, we can just remove it with surgery, and that may be the end of the treatment. Sometimes if we have a tumor which is larger for surgery but it is still localized, then we can give some chemotherapy, make the tumor smaller. Sometimes the tumor engulfs the blood vessels and the neurons in and around the tumor space. So when we give chemotherapy, the tumor will become smaller, this encircling of the blood vessels is gone, and then the tumor can be removed surgically. Very occasionally, we may need to give radiation to the tumor bed. So with all these modalities, we complete the tumor, and these patients with low risk or earlier stages tumor, generally stage 1 and 2, are cured with this treatment. Now come the intermediate risk, where we have a little bigger tumors with crossing the midline of the abdomen, huge tumors. So we need more chemotherapy. There also we try to remove the tumors with surgery after a more number of cycles of chemotherapy. Then we also give radiation, and then in some of these cases we may have to give some more treatment with monoclonal antibodies or 13-cis-retinoic acid for maintenance, so that they are having a longer remission. Then there is high risk tumors, which generally are metastatic tumors. Stage 4, they need only control of the tumor for as long as possible, say 3 years, 5 years, whatever is possible. They are generally not in the curable stage, and these tumors also, once they complete the chemotherapy and they are in good remission, they are given this 13-cis-retinoic acid and sometimes the monoclonal antibody called rituximab, and with that they have a long event-free survival. Now there are some neuroblastomas which occur in infants. There we may just need to observe them. There may be some skin infiltration and the tumor may look very advanced, but if we just observe them for some time, in the next 1 to 2 years the tumor will subside on its own. It is called spontaneous regression. So also in tumors which occur in children who are just newborns, less than 6 months old, they may have just the adrenal gland tumor, where just observation may reduce the tumor by itself. It is called spontaneous regression. Sometimes they may need little amount of chemotherapy with which the tumor will subside totally. They may not need surgery. These are all the methods by which neuroblastoma is managed. Very occasionally we may need bone marrow transplantation. It is called autologous bone marrow transplantation to consolidate response in the neuroblastoma which has occurred with chemotherapy, and there we prolong the remission free interval with this autologous bone marrow transplantation.